Okay, we're ready to start?
I'm ready to start.
All right. Well, welcome. This is Gerard Gioia. I'm the Division Chief of Pediatric Neuropsychology, and I want to welcome you all to the Children's National Health System Lunch and Learn today. We're going to be discussing new strategies and tools for managing concussions in kids. We're going to talk about a systematic pathway and process for the clinical care of individuals suspected of and diagnosed eventually with concussion. And also I'm going to introduce a variety of tools, some of which may be ones that you are familiar with, but others that are maybe newer to support the evaluation and management across the recovery timeline. Just as a brief background here, the definition of concussion is that this is a process where there is abnormal physiologic process due to a traumatic biomechanical force that's been applied to the brain, either directly by the head being hit or indirectly by the body and the head being thrown forward or backwards in a high velocity sort of way that then disturbs the brain and its functioning. And that this is due more so to the brain's metabolism and its neuroconduction being disrupted rather than necessarily a structural injury such as tissue damage or tissue tearing. And this, as a result, typically results in normal findings on our more standard neuroimaging modalities such as a CT or an MRI. We know that concussions, mild TBIs, typically do not involve a loss of consciousness, and some of the data more recently suggests it's 10% or less. What then happens, of course, is that the injury produces a constellation of symptoms in a variety of domains, physical, cognitive, emotional, and sleep, that can vary in terms of their duration. So you can have individuals that have a very, very short duration of minutes or several hours, but it's also quite possible, in fact, we'll learn quite, not unusual that this can take weeks, maybe even up to a month or so, and in some cases even longer than that. So I have this figure here that shows a picture of the brain inside the skull. What we can see in it is that there is a, as we know, fluid that surrounds the brain as it's encased in the leathery pouch called the dura mater that allows somewhat of a shock-absorbing system, but of course there are limits to that, and it is when those limits are exceeded and there is a stretching and straining of the brain tissue that we then see some issues, and we'll talk more about it. This actually is a slide that unfortunately I can't get it moving in the way I want to, but I can at least describe that my colleagues, biomechanical engineering colleagues at the University of, or at Wake Forest School of Medicine have put together, and it shows how the different layers and the different aspects of the brain move and stretch and strain in different both velocities and at different times. It just gives an idea of what that stretch strain process is all about. What we know is that when the injury does occur, and so in the middle we have the picture of these two girls playing lacrosse, say that the stick hits in the head, and relatively infrequently do we see that loss of consciousness, but we do see more frequently some interruption of the information processing systems. And so we talk about the difficulty or the lack of memory consolidation for information just before the injury and also just after the injury. And before the injury is called retrograde amnesia, and afterwards is anterograde amnesia. And this is disruption of the brain systems that encode and store new memories. And we see that that happens only up to about 40% of the time. So again, that's not certainly a universal phenomenon, but it's something we want to be aware of. What we then see is that there are a variety of symptom manifestations that we want to be assessing, cognitive balance, vestibular, ocular motor, and that these symptoms can last for anywhere, as we said before, from hours to days to weeks, or maybe even out to months. And that this injury is modified in terms of its manifestation to some extent by someone who comes into the injury with certain pre-injury risks, and we'll talk more about that. So this helps us to kind of conceptualize how the force to the head produces the kinds of functional changes and potentially relates to the type of recovery trajectory that we might see in any given patient. So in sort of looking at that as the background, a little bit of setting the scene here for really then how we want to move forward in the primary care clinical pathway. So I'm going to review that here, and we've developed a pathway that really starts from the injury itself being reported to the office, all the way through to recovery or to referral to a specialist. And we're going to go through these steps and with some of the tools here. But thinking about this in a systematic way, I will also mention that we are doing this in a much more expanded and in a much more competency-based way through an MOC process that the American Board of Pediatrics has approved. Now, I will say that that program is now currently active and underway, so we don't have any more opportunity for new participants or registrants, but we will probably be repeating this over the next year, and I sort of throw that out there because today is in essence sort of the front end of what we typically do with that MOC process. So again, the pathway here, I like to think of the event, what would happen in the office, what action we would take, the tools we would use, and what kind of communication we would be undergoing to make that information known across the child's system. And again, this goes from literally the beginning of first phone call all the way through to recovery. So injury notification, typically a phone call to the office, our initial visit where we're doing more diagnosis and the initial management, out to then a follow-up on some periodic basis to either clearance, or if we're seeing a patient that really is having a more prolonged recovery, we look at what criteria we might use for referring them on to a specialist. So in the CDC heads-up toolkit for healthcare providers, one of the things that we wrote in there was kind of some indications or trigger conditions that a practice should think about employing in order to, be reasonably assured that you are screening a possible brain injury or concussion. And so high-speed activities, such as somebody who is moving in a motor vehicle, somebody who is riding a bicycle or skateboarding, or something where it's a high-speed activity that then results in an injury, we know that the head can move, again, whether directly striking something or in itself whiplashing. Certainly, we've heard a lot about the sports and recreation world these days. Falls, particularly when they happen from some distance, but again, we should at least be alerted to any fall, and we know that that happens more so with younger children. Certainly suspected child maltreatment. We know that child abuse is a situation where oftentimes we see an injury to the head. Now, obviously, exposure to blasts is something that does not happen a lot in the United States, although we certainly see it with our military members. Or any external injury to the head or to the scalp, we should be screening. And in doing that, if we think about it, taking that initial phone call, and then the action would be to determine, do you come into my office, do we send you to the emergency department? The reality is that most individuals, children, adolescents, adults, with this injury do not need to go to the emergency department, but there are certain conditions in which they do. And the question, the challenge really for any practice is to decide how do we put that triage process systematically in place. And so we have a couple of tools here that we'd like to offer as possible things to assist you. And so the idea would be a trigger condition is identified over the phone or in some other interaction with the practice, and we would ask the questions. Number one, was there a blunt force to the head, or did the head move back and forth with a lot of force, like whiplash? So this is kind of asking about the mechanism kind of issue here. If yes, then we move on to ask if there was a change in mental status and neurologic function and level of consciousness. In other words, were there signs that would tell us that something may have changed in the brain? Again, if there's yes to that answer, then we want to make sure that we're screening out the red flags, because the likelihood of a concussion or a brain injury is elevated when we have positive answers to those first two questions. But now we need to know if there is this level of severity that might suggest the possibility of neurologic deterioration that would then send that youngster to the emergency department. And so we've got the 12 red flags here that, headaches worsening, seizures, neck pain, somebody who's just significantly irritable for reasons that seem to be sort of unclear relative to the injury, significant drowsiness, or the patient can't be awoken, repeated vomiting, slurred speech, unusual change in behavior that just does not seem, again, characteristic of this kind of an injury, or there's disorientation. They can't recognize people or where they are, or there's confusion that really is present, or if we see some of the motor kinds of findings like weakness or numbness in the arms or legs, and obviously, and I say that term quite explicitly, quite obviously when there's a loss of consciousness. So those kinds of things would suggest get them to the emergency department. Because we don't oftentimes see these kinds of red flags, assuming that's the case, then we would then consider moving them along to the practice. And so in using an example here, we have JT, who's a 14-year-old ninth grader, happens to play soccer and basketball and lacrosse, but actually was injured skateboarding. Fell, struck the back of his head on the ground, didn't appear to be any loss of consciousness, but really could not remember what happened 5 to 10 minutes prior. He remembers actually getting on the skateboard and skating a little bit, but the injury actually happened well down the road, and he does not remember that 5 to 10 minute period. And then he had 10 minutes of post-traumatic amnesia. That is when he's asked, what do you first remember? He remembers being back home and not that 10 minutes that happened in between, and he was clearly confused. So the parent calls the office, and now we get into what's the nature of the injury. Well, we see a blow to the head, a fall. We should now initiate these triage questions that we've mentioned here. So again, think about blow, force to the head, producing some kind of alteration of consciousness or neurologic mental status change here, and we think about the kinds of signs and or symptoms that we see here. So those are our two triggers that we want to put in place. And a positive response to both triage questions triggers that evaluation, and again, triggers the screening as well, as we talked about here, because it's very important that we know when that smaller percentage of kids needs to go on to be seen at the emergency department. The absence of the red flags, though, would signal a reasonable or a good reason for being seen in the office. So in our case here with JT, the blow to the head was confirmed, concurrent signs and symptoms were reported, no flags were identified. So he's scheduled now to be seen in the office the next morning for further evaluation. And so in that office now, we want to confirm the diagnosis. And so here we developed the acute concussion evaluation for that purpose.
Doesn't remember the event? No, doesn't have.
Oh, it looks like we have some competing voices here. Anyway, so we use the ACE, and again, we're communicating those results, of course, to the family and ultimately to the school, which we'll get to in a minute here. But now the next step really is educating that family and developing that initial management strategy. And I'm going to share with you the CDC instructions that we have developed, and as well talk about the care plan that we developed here, and give some guidance about, certainly during the school year, returning to school, whether or not, and what you would do from a sports, physical education, recreation perspective. So, again, that injury to the head occurs, and we use our clinical protocol to identify, diagnose, and then educate and manage it. Some of you may be aware of the heads-up brain injury in your practice toolkit that was introduced 10 years ago. It's now been updated, so it's for all healthcare providers that might see this injury. And inside that is the acute concussion evaluation, or the ACE, that we developed here. And the whole idea behind the ACE was to really improve the physician's early diagnosis and to have data to guide their initial management in a very individualized way. From the public health perspective, we thought this was important too, because the better we identify it, the more we can understand the epidemiology of the injury. Really important when we talk about the assessment that we recognize some essential elements, and that is to recognize early on the difference in that person's functioning, and that's where we really go in and ask the kinds of questions, you know, how has this individual's behavior or physical function changed from their typical way? And knowing, again, detecting that change reliably from their usual functioning, we're going to talk about how the pre-injury history is an important context here, but that we also be sure that we are assessing the totality of the symptom categories and not just a few symptoms here and there. Did you have a headache? Did you have some memory problems? But we get good coverage across all the kinds of ways that this injury can manifest. And that we monitor that symptomatic functioning over time for change and for recovery, or again for the potential of persistence in a way that might suggest we need to do more in terms of the treatment. But that we also are educating and guiding recovery in a standard way. And then ultimately detecting when that individual is returning back to their normal self, their usual self, i.e. meeting the criteria for recovery. So these are kind of the elements that sort of are part of our assessment and management process. So the ACE, again, was a clinical protocol we established to just assist the diagnosis of this injury, both in emergency departments and in the pediatric office setting. It was built for kids as young as 4, goes all the way through to adults. And at the time, we were really drawing on as much evidence as we could to include in this and then link it again to a management or follow-up plan. We have a couple of papers that we published on the ACE. This is the evidence for its validity and reliability that demonstrates how the ACE can in fact relate to and predict later outcome. And then we have a paper that was published in Pediatric Annals back in 2012 that's more of a written description of the use of the ACE and the ACE care plan. So again, the ACE is a system where the patient or potentially the parent, if the patient is not able to, can report the signs and symptoms, again, across those 4 categories, including 22 symptoms, and it takes about 5 minutes or so to complete. So what we're doing, again, is we're defining the nature of the injury, assessing for the symptoms, identifying those risk factors. Now, again, we've already done our red flag assessment, but once we've done these things, we are now establishing an appropriate ICD-10 code, diagnostic code, and then a follow-up plan. And again, we're going to link that to treatment with the care plan that we'll be talking about here. So with the ACE applied to JT, he presents to the primary care office 1 day after the injury, and the evaluation includes the ACE. It includes a basic neurologic exam, and we get a good background history on medical, developmental, psychiatric kinds of issues. What we've identified with JT is he's reporting headaches and nausea, dizziness, balance problems, fatigue, sensitive to light. His vision's a bit blurry, and he's having troubles concentrating and with some mental fogginess and slow thinking, as well as irritability, and then some drowsiness and greater amount of sleep at this point. And what we see is that he reports that when he's walking around, going up and down stairs, these symptoms worsen, and when he's trying to read something or do some cognitive activity, they worsen as well. And so we look at this and we can fill out the injury characteristics here on the ACE and start to fill in that there's evidence of the forcible blow, As far as we know, there was no other evidence of skull fracture that, in fact, the causes and the early manifestations. So it allows us to know, were there amnesias, was there LOC, was there any other presentation that we need to record in terms of signs. We then go into the symptom checklist here, and what we did with the ACE was to decide that this was only going to be a present-absent process here. Now, I'll show you an example of a graded symptom checklist in a few minutes, but the bottom line here is that the initial evaluation in establishing the diagnosis and getting an initial definition of the problem, we really want to know, were these symptoms present any more than usual today or in the past day? So any more than usual is the critical factor. That allows us to sort of take the baseline of these symptoms into account. We also ask, again, whether the symptoms worsen with exertion, and we ask an overall rating, like how different do you feel from normal? Again, either of the patient themselves, or if they're incapable at that time of reporting on that, you can ask mom or dad, how different do they seem right now? So, again, think about how we use that term more than usual as a way of sort of taking into account the baseline. When we think about our physical exam, again, in general, we're looking for some of the external kinds of signs, such as bumps, bruises, any obvious fractures. And then we look into the neuro exam in a variety of ways. We've been interested in now more and more the eye or the ocular motor issues here, looking at smooth pursuit, saccades, the ability of the eyes to converge appropriately. Pupillary light reflex is not something typically we see as a problem in concussion, but it could be used to rule out something more significant. And then we want to look at the neck, and this is important because certainly with the neck, particularly with whiplash-related kinds of mechanisms, what we see is that that can be a secondary problem that results in some posterior headaches that can contribute to the other more central headaches. And we want to take that into account because there's some very direct treatments we can put in place. So we look at range of motion, any muscle tightness. We look at general strength and tone, sensation, of course, and we think about that in upper and lower extremities. Coordination, we're looking at finger to nose. You can also do lower extremity, heel to shin. And then we do a gait where we're looking at, heel, walking, toes, tandem gait, and then we're looking at Romberg signs. So these are the things you would probably more typically do in your exam. And many times we see that the general medical exam, general neuro exam is fairly insignificant. But there are times when we pick up important findings, particularly in the ocular motor, the range of motion, and in the coordination kinds of areas. So the other thing that's really important, and one of the reasons why I think it's so critical that kids come to their medical home for the initial evaluation of this injury, is that history matters here. This injury is happening in the context of a youngster's medical and school, educational, developmental, and emotional or psychiatric history. We also know that these concussions can mimic, or let me just say the symptoms of a concussion are very similar to the symptoms we see in many other kinds of disorders, and we have to take those things into account. So when we do that, we want to understand in an individual, say, that has attention deficit, is their problem concentrating and with kind of that initial short-term memory more than usual a problem. And so it's not something that we want to ignore because we've got to contextualize these kinds of things. So in moving on, when we look at that on the ACE, we actually see that there are these risk factors built into the evaluation. And we also know that there is some evidence that some of these kinds of premorbid or pre-injury factors combine with the injury itself and can produce sometimes a more prolonged or a longer time to recovery. And so we want to take these things into account, not only for establishing the diagnosis and understanding of these problems are above and beyond the premorbid history, but also sometimes these things can relate to a longer recovery. I want to take a minute just to talk about the concussion history piece itself, because we know that your concussion history may also relate to your outcome. And in particular, we're concerned about this when a previous concussion occurs relatively close to the last injury. And so if we have an injury that occurs within a few days or even a few weeks of the existing injury, there may be a combination or an accumulation of effect here, and we want to know about that. It also is going to relate to our management and how we would allow someone to go back to a risk activity in that we're going to be much more conservative in that regard. But also we want to know, again, about that headache history. We want to know about, again, developmental issues. And we want to know about the psychiatric history. We certainly know that concussions can affect, of course, the emotional regulation. But if somebody comes into this injury with anxiety, this can really ignite those issues and can potentially interfere with recovery. And so we definitely want to be tracking those things. Again, we want to establish the diagnoses, and so the original version of the A still has the ICD-9s on there, but we also want to look at, obviously, coding with our ICD-10s. So concussion with no loss of consciousness, concussion with a loss of consciousness, a brief, and typically, again, these periods of loss of consciousness are relatively brief. And at times we have a scenario where we're not sure if there was a loss of consciousness, and it may be unspecified in its duration, and we might use the 9 code there. So we want to code these things, properly with our ICD-10s. And then there are times, although it's fairly infrequent, that we see kids where there actually may be positive injury description, associated symptoms, but there is evidence of an intracranial injury, loss of consciousness greater than an hour, and now we start to go into other, or 24 hours depending, and we want to go into looking at moderate TBI, other kinds of codes that might suggest, a more severe presentation. So we put that on there as well. Now, I also want to talk about sort of the diagnostic confidence criteria that we're beginning to apply as we think about this, because, again, there are a variety of ways that these injuries can show up, and it may show up on the day of the injury or the day after the injury, but there are also times when we hear from kids and families that an injury may have occurred, days or weeks or even months ago, and now there's a change in that person's functioning, and the question is this concussion or not? And so we've been thinking about this, the CDC is thinking about this, some of our research colleagues have been identifying this. Number one, we want to establish, was there a definite reported mechanism of injury? And was there an onset of typical symptoms within a relatively coincident period of time? We talk about 24 to 48 hours. The way that the neurometabolic neurotransmission dysfunction occurs, it would be unusual that the onset of a neurologic effect would be delayed beyond that period of time. Now, there may be some difficulties that the family or the child has with identifying and the nature of why they're feeling different, but that's a different story here. We're talking about where there is no evidence of any onset of symptoms or signs within that first 24 to 48 hours. And the other thing we look at is that most of these injuries, again, have a period of gradual recovery or at least some stability of symptoms, and typically not a worsening for no good reason. And so we think about, again, the normal process of the recovery of the brain's activity in recovering, resulting in, again, that gradual reduction of symptoms or improvement of symptoms over that first week. And then finally, we want to look at whether there's an alternative explanation for the symptoms that would really indicate that it's not a brain injury per se. So, for example, somebody maybe has some blow to the head, but really no evidence of the onset of symptoms at the same time. It's really the same migraine I usually get, or we might see that it's an exacerbation of elements like anxiety or ADHD, and it's really not a primary disorder of the brain. And so we've got to be sure that we are putting together these kinds of factors to give us the confidence that, yes, that mechanism that is reasonable resulted in this typical onset with a course of recovery that makes some sense and not explained by other kinds of factors. So we look at that, and we can begin to have confidence. Sometimes you may want some help in confirming that, and that's when you might refer on to a specialist to confirm what seems to be somewhat of a muddy picture here. So again, we think about the fact that there has to be the coincident period of time of that blow to the alteration of consciousness or mental neurologic status. Then we think about what do we do now? Okay, we've established a diagnosis. We now need to do follow-up here. And so we're going to talk about that process of managing and what we do. And I think it's critically important that we at least spend a little bit of time educating our families about the nature of this injury and what they should expect and what they can do, certainly reassuring them that they're going to see good positive recovery and what they can do to maximize that. So when we manage the recovery, we have the ACE care plan that we developed that we're going to talk about in a minute here that really helps us to take what are those symptoms that we identified, how do we begin to manage them in careful ways. So the general principles that we want to apply here in assisting recovery is we, of course, want to reinforce to families that there be no additional forces to the head or brain. We know that that brain is much more vulnerable to re-injury when it is still in the recovery phase. So we have to ensure nothing is going to re-injure. We want to make sure they get good nighttime sleep. It's really important for not only the recovery process, but also for the ability to get through that next day, that we've got good energy and restoration of energy through sleep. And then the big issue here really is managing and facilitating recovery by either not overexerting the body or brain during recovery, but also not underexerting too. So avoiding things that produce symptoms. And we know that we can overexert physically, that is somebody's running around, they're jumping up and down, they're carrying heavy things, they're doing things that are exacerbating their injury. Cognitively, where somebody is engaging in schoolwork or other kinds of activities, reading books for hours on end, over-focusing on activities, but also stress, so emotional exertion, if you want to call it that, can also result in an exacerbation of symptoms because you're really resulting in there being a significant energy drain with that stress reaction. It's real important that we deliver the positive message, though, because kids do get better from this injury. Of course, the individual challenge is what symptoms they have and over what period of time, but really important that we convey to families and to kids that they're going to get better, they will improve and recover over time, that what they have control of is what they do activity-wise that does not worsen their symptoms, but also does not result in them being underactive. And so their efforts to control their activity and time are going to pay off. And we really talk about finding their sweet spot of activity, gradually increasing that activity as much as they can tolerate. But I also want to take this four-letter word called rest and substitute it. Because really what we're doing here is we're actually helping the family learn how to manage activity across recovery. The brain actually does a pretty good job in redistributing those chemicals back to their normal state, normal concentrations within the cells and outside of the cells, and also electrical conduction through the axons is also recovering over time, and our job is to manage our activity to both facilitate and not interfere with that recovery process. So we developed a set of patient-family education materials with the CDC over this past year, and it's really for patients to take home, and it's all about what to do after a concussion. Make sure you follow up, of course, with your medical provider, understanding the nature of this injury. When would you go back to the emergency department? And then thinking about, or at least educating them as to the kinds of symptoms that they should be monitoring over time, and what steps you can take to help your child feel better. And here's where we talk about the reintroduction of activity. In the first few days, though, we talk about doing it much in a more restricted way, limiting activities that cause symptoms to worsen, ensuring that they don't re-injure themselves, again, helping them to avoid taking on too much too early, making sure they get good nighttime sleep, and again, being positive about this recovery process here. Again, stepping up into light activity, moderate activity, and so you're doing a gradual kind of introduction of both physical, cognitive, social activities. And then what do I do if my child's not getting better? Again, here's where you might refer on, and we're going to talk more about that in a minute. And then assisting kids get back to school with some assistance, and we'll talk more about that in a minute. But again, we want to prepare families for what the likely recovery map is going to be here. The other thing here is communicating our findings as healthcare providers to the school. It's really important that the school be aware of the injury and be prepared to assist and support the youngster in their return. And so we've developed this return to school letter that identifies when the injury occurred, gives a little bit of information to the school about the fact that recovery typically takes several days and several weeks, and that they really need to understand the nature of the symptoms. And so you would fill out the symptoms that the patient is experiencing. And so in JT's case, we filled these out. And then we think about when that youngster would go back to school. I like to think about them staying out of school for a day or two to get a sense of how that symptom burden is progressing, but also thinking about when might they go back. And so if the child can begin to do some activities involving concentration for about 30 minutes before the symptoms really get worse, and that the symptoms, when they do worsen, do actually recover or resolve a little bit when they take a break, then that's a good sign for them getting back to school. But the other piece, of course, is making sure that we inform the school of the safety restrictions, not doing physical risk activity during recess, not participating in sports, not doing physical education, and there may be other activities that are specific to that youngster, but we want to make sure we're communicating that right away, because we certainly have seen cases where that's not communicated and kids get thrown back into gym or to other risk situations here. We also, though, suggest that, the kids can walk up to class, they can do certain things that obviously they can tolerate here. So that's very important that we communicate our findings to the school. And again, that's available in a letter that we can send out. On the back of that letter is some suggested school supports that the youngster may have that are very specific to the symptoms that they have. So we want to tailor the supports, the recovery supports, based on the symptoms that the youngsters have. So it's very important. We don't want to throw the kitchen sink at the school, or they're not going to know how to do that. So if we take, for example, difficulty concentrating, we might talk about, can we shorten the assignments? Can we decrease the workload? Can we give the youngster some breaks so that they're able to maximize their concentration? Or have somebody kind of work with them or give them more time to complete the assignments. So there are a variety of things that we can do there, okay? So that's kind of the communication with the school. Then we get to now, at the end of our first visit, patient is sent home, they've had some initial education, they've got that initial plan, they're going to bring the letter to the school to let them know what the first steps are, according to your management. And then you schedule some follow-up visits, and it's very important now that we really track this recovery over time, monitor those symptoms, monitor how they respond to doing various activities, what we call the exertional response, and then, again, get some idea as to how they're doing at school. And we use a couple of different possibilities. You can use your ACE symptom checklist, again, where you're basically finding out is the symptom present or absent, or you can do a graded symptom checklist. It's what we do in our clinic. This tells us, is the symptom present a lot or a medium amount or a little bit? And now you can begin to see the trajectory of recovery here. So here's an example of the symptom checklist that we've developed for kids 5 to 12. This is a validated tool. It's funded by the CDC. It's used by NIH, so it's got some good evidence behind it. And the first 5 items are ones that we use with kids that are 5 years or 5, 6, or 7 years old. Okay, only those 5 items. If they are 8 or older, we then add the other 12 items, so now they have a 17-item version. And what we can see is that we actually ask the youngster, tell us about the injury, or sorry, the symptoms before the injury, tell us about the symptoms today or yesterday. So again, what we do here is we explicitly build in sort of that baseline, and then we can develop, in essence, what's an adjusted score. You know, what is going on that's specific to that injury, and really taking account of their pre-injury symptom manifestation. Here's the same copy that we, or same type of instrument that we use with adolescents. They have more items, but again, it's pre and post injury. Again, an adjusted score here. They're categorized by physical, cognitive, emotional, and sleep fatigue items there. It makes it easy to kind of quickly score that up. And then we also ask the parents to fill these out. And let me say that we actually hand a clipboard to people to fill these out in the waiting room, and they can do that prior to coming in and seeing you, so that you've got that information sitting in front of you when you are meeting with them clinically. So again, we have one for the child, we have one for the parent, and based on the age of the child, they'd get a different tool set. And again, we can make these available to you to use. So ongoing, management now really is, again, prescriptive. We use the ACE care plan to define those symptoms, to reinforce making sure that they're balancing how much they do and how much their symptoms might increase exertionally. We make sure that we reinforce the sleep recommendations. We let them know that emotionally this can be a tough injury to handle, but they're going to get better. And then we give them, again, the ongoing guidance. What can you do during the day? What can you do at school? How much physical activity can you engage in? And when can you return to your sport? So the ACE care plan really kind of sets up that, and we literally use that almost as a script as we're working with our families. So again, it's important that we make sure that during our management we reinforce protection and risk from any further risk activity, i.e. re-injury, and then we manage their activity and gradually introduce things over time. So again, with our care plan here, as I said before, we identify those symptoms, and then you see the key points here. We reinforce the sleep issue. We reinforce that they balance their activity with breaks, particularly when symptoms worsen, and that they use their symptoms as their guide. And we like to reinforce that key rule for activity. I don't want you to do too little, sitting around doing nothing, but I also don't want you to do too much, such that it increases your symptoms. We reinforce that they're well hydrated, that they maintain a good, balanced diet. And again, we acknowledge the fact that emotionally this can be tough and frustrating, give them some support around that. For adolescents who are driving, if they have a high symptom burden, we really do not allow them to drive until they are either fully recovered or just minimal symptoms that have any effect. And we usually ask that parent go with them the first few times just to be sure that they're doing all right. And then we use this as for school now, returning to school, we have those recommendations down below, the different accommodations that, again, can tie into the kinds of symptoms, such as taking rest breaks if they're fatigued, if they have significant symptoms of headache or difficulty concentrating. We might reduce, again, the load at school, make sure that there's only essential work that's done, that maybe taking no tests or modifying them such that they can handle them appropriately. And then returning to physical activities. And so, again, part of our management strategy has changed over the years, and particularly as kids start to approach the beginning of the second week, I like to see them doing some low-level physical activity that does not worsen their symptoms. And of course, that is non-contact risk associated. And so we give them guidance about that. What are the things you might do? Can you take a walk around the block? You know, take the dog for a walk. Do you have a light stationary bike available to you? Do you swim where you can do some aerobic activity? Something that increases the heart rate, but again, at a low level and maybe for only 5–10 minutes to start with, but then gradually increasing that as you monitor your symptoms. Clearly, kids do not return to sports or physical education until they are fully recovered. And so we know that our state laws are such that it requires us to clear them to be fully recovered before they go back to those risk activities. There are some times, though, when we will have an agreement with either a sports team that we trust or a school that we know that may have an athletic trainer, where they start to do a little bit of exercise and skill work within the context of that sport, but again, in no way exposing them to injury or re-injury risk. And then a gradual return to play process we'll talk about when they're recovered. So again, we think about this, you're following the youngster over time, and ultimately we want to look at what are those criteria for recovery. And again, most kids are going to recover within a matter of weeks. A study put out of Canada last year, the 5P study that some of you may know about, that I participated in, looked at 3,000 kids and found that 70% of the kids were asymptomatic within 4 weeks of time. So most kids are getting better in a relatively short period of time, but 4 weeks is not insignificant, and there's 30% that still had difficulties after that time. So we're knowing that the criteria for recovery, no symptoms at rest, no medication used to manage those symptoms, no return of those symptoms with sort of typical, you know, physical activity and cognitive activity, i.e. school, that there's no problem with our typical cognitive functions. And I like to use school as kind of the example there. Are you learning? Are you remembering? Are you performing in the way you typically do? We would do a balanced coordination exam, and there's no other medical neurologic complaints. So again, we can use our symptom checklist. We can do our medical exam to identify this. So again, here's our criteria again for final medical clearance to return to competition. And you'll notice the last one, number 6, is that they successfully complete a gradual return to play program. And the gradual return to play program is something that is very important. What it does is it introduces several different increased demands. First of all, a general metabolic demand as we increase heart rate, making sure that no symptoms come back with that. We introduce movement to make sure that that does not reintroduce any symptoms. We bring on the strategy or the cognitive side of the sport activity, and then in a contact sport, we introduce a controlled light kind of contact initially to make sure they can handle that without symptoms, and then a controlled scrimmage. If they go through those steps without having any increase in symptoms, then they are cleared now to return to full participation. And typically, again, that's done by an athletic trainer. There are some sports PT sites that do that as well. Now, recovery can be complicated, again, in a certain percentage of kids. Again, maybe anywhere between 10 to 30% of the kids. And here's where we want to look at making a referral to a specialist. And so when recovery is complicated, the criteria here we think about here, so a complex injury. That is, we've got somebody who's had multiple blows within a short period of time where you're concerned that that injury may be of a greater significance or severity. Where there's persistent overall symptoms, where you notice that, you know, after 2 weeks, there's not a whole lot of improvement. That is, and we sort of arbitrarily say, you know, less than 20% symptom improvement. There's no change in their cognitive performance or functioning. That is, the youngsters still having a lot of troubles with attention, concentration. You'll notice there's one item here where we talk about the need for intensive school programming. That usually accompanies those kinds of cognitive challenges. Or there's the presence of risk factors. That is, you have somebody with a complex medical history or psychiatric issues or learning disabilities, attention disorders, where it's difficult to know, again, is that contributing to this recovery that's taking longer, is it not, and you want some help in kind of disengaging that. Again, we talked about the persistent cognitive difficulties or school problems. Sometimes, again, we have kids where they have such a significant emotional response to this injury that it's possibly interfering with the recovery and need to see somebody. And then somebody's just got a history now of multiple concussions where we really want a specialist to look at that with the family and decide, A, is there a way we can prevent further injury? B, what is their vulnerability, and should they be returning to sports or other kinds of activities? And then sometimes you may feel less comfortable either in confirming that they are recovered and need some guidance and some consultation on the clearance for that youngster to return to risk activity. So there's a variety of different criteria you might use for specialty referral. So in summary here, it's important that we establish a procedure. We've given you kind of that workflow, that patient kind of flow from the initiation of the phone call, using the trigger conditions, asking and documenting the 2 triage questions, making sure that we have covered the red flags, know whether they go to the emergency department or not, putting a procedure in place, whether that's somebody literally who's answering the phone being trained on that process or some other way that a clinician might do that. Again, assuming they're coming in at some point for office assessment, using your tools, the ACE, and a good neurologic exam, and making sure that you're taking account of history here to either contextualize the injury to say this is not related to their history or it's an exacerbation of the history, or actually what they're presenting with, at least in part, is really what they were beforehand in that history, such as inattentive or anxious or having headaches, and is not related to the concussion itself. We want to, again, establish a diagnosis, but employ those 4 diagnostic confidence criteria so that we can say we've got that mechanism, the injury manifestation, that is the symptoms and signs, were coincident within a relatively brief period of time, 24 to 48 hours, that there has been a reasonable course of recovery over time of those symptoms, and that there really is not an explanation primarily by another cause or another reason here. And so it's important that we apply those. And then that we educate and prepare families for what to do next after the injury, after they're leaving your office, to know that these kinds of symptoms are present. These are the kinds of things that might worsen if we do too much, but we should also be sure that we don't underactivate the youngster, knowing that the first few days are going to be a bit more restrictive, but over the second part of that first week and on into the second week, we really want to start gradually introducing things they can tolerate. We make a decision about the return to school. Are they ready to go back tomorrow? Do they need a few extra days? Some of the things we're learning is that the higher the symptom burden that the youngster presents with, the more likely they're going to need a few more days out of school. But again, we want to get them back as soon as we can, even on a partial basis, so that we can ensure that they're getting back into their routine. Again, schools are becoming more sophisticated in how they begin to manage, but you, on the back of that return to school letter, have some guides you might offer the school in terms of symptom-targeted academic supports that youngster can have. So think about using those tools. Definitely follow kids over time to monitor their progress, and then as we look at the criteria both for medical clearance, most kids that you're going to see in your practice are going to have reasonably consistent and regular recoveries. Others are going to have, and again, a smaller percentage, and maybe have a bit more of a prolonged recovery or a more complicated recovery, and then we want to think about the criteria for referring them on. So those are the kinds of things that we want to think about in really making sure that the primary care practitioner is really the quarterback of concussion care. A study by the Primary Care Network up in Philadelphia, associated with Children's Hospital of Philadelphia, when they put good systems in place, including training, electronic health record materials, good protocols, 82% of the kids over, I think it was a 2 or 3 year period of time, were being seen for their first visit by the primary care provider. And that, I think that's really quite commendable because we know that the medical home is really an important place to understand the injury, to contextualize the injury. But then you'll have the confidence to know, am I able to see this youngster through to their recovery? Do they need to see a specialist or not? So I'm going to stop there, and that is where we are now and looking at new strategies and tools for managing concussions in kids. I don't know if we have time or the capacity for a few questions. I will leave it to our webinar host to let us know if that's possible.
Yes, we have time for questions. I'm unmuting the lines.
Feel free to ask any questions you might have. No question is out of bounds.
MLC, but too much time consuming.
Yeah, I thought it was too. I tried to.
Okay, so I'm not sure I'm hearing any questions, or am I?
No.
No? Okay.
Gary,
yes.
This is Jim Matty. Can you hear me?
Yes, I can hear you, Jim. Thanks.
Thanks for the presentation, by the way. I was just wondering, do you guys have easy access to sort of all of the forms that you have together here? We've got a scattering of them, but I'm wondering if there's a download thing.
Yeah. So, well, there's a couple of options here, and I'll see if anybody from the Children's Hospital side can provide that easy place. We've talked about actually doing that on our website, having a place for providers to be able to pull the forms off. But I can also send a link to our Dropbox that actually has all these forms in them. So if we can get a name and a place, an email address, we can send that to you, or we might be able to post some of these on our website. I'm not sure if we're ready to do that yet or not. Elizabeth, I don't know if you're on the call to tell us that. I mean, one option would be, so Jim, one option would be to email me, and my email is ggioia@childrensnational.org. Actually, I'm going to put it literally on the right now on the site on this slide, childrensnational.org, and I'd be happy to get those over to you, to anybody who would like those.
Is a good example. When he smacked his head on the
Great.
basketball.
Thanks, Jerry.
Sure.
He came in the first day with a concussion. We didn't understand. They didn't understand what was happening. And when I said, yes, you have a concussion, and here's your return to learn, he got better at home. Then he went back, and his first day back, he came home from school on the bus with a big hip state.
The first day back, he what? I'm sorry? Was that a question, or I'm not sure if that was a conversation or a question? Actually, just it may not be a question, but I'll comment. So, clearly, kids, when they get back into a demand school situation, if they don't have the accommodative supports in place, they're going to have a lot of challenges. And again, I think our schools are getting better at it, but they still need some help, and they recognize that. And I think we can begin to guide a little bit of that process. We've been trying to do educational seminars for them as well. But again, I think it's real important that there be somebody at the school that can monitor that process and make those adjustments so that kids do have a successful return to school. And that is frankly the biggest challenge that we face when we're helping kids in the recovery process. So, Well, we've come to the end at 1 o'clock, and so again, I thank you all for your attendance at the Lunch and Learn today. And again, if there's any questions or anything on follow-up, I'm happy to send either forms or answer questions you might have. My email is right there on the screen, and let us know what we can do to help you out. So thanks again. Bye-bye now.